I'm happy to kind of lead things off by sharing with you kind of my impressions about current therapies for Alzheimer's disease. And the question is, do they work, and are they worthwhile prescribing? I am not going to be covering the most recently approved aducanumab, but Dr. Morley and I decided that we will kind of both give our opinions about it after our presentations, because I'm sure many of you have questions about it. All right, so these are my disclosures. I think you have them in the earlier slides. And we're going to be basically evaluating and contrasting the currently FDA-approved pharmacologic therapies for treating patients in the spectrum of Alzheimer's disease, from mild, moderate to severe. And we'll look at the evidence, particularly for combination therapies, combining a cholinesterase inhibitor with the NMDA receptor antagonist memantine, and what their impact might be on cognitive functions, activities of daily living, kind of global clinical outcomes, as well as behavior. We'll also kind of look at the anti-dementia therapies in this way, and then come up with some conclusions. So this is the current landscape. You do not see aducanumab on there. So my new slide, which I'll be creating, would have aducanumab as the most recently approved treatment for Alzheimer's disease. It is a monoclonal antibody, or kind of an immune therapy, basically geared toward pulling out the plaque, or the A beta and the amyloid plaque, from the brain, with the notion that by kind of removing amyloid from the brain, we may be able to slow the disease down, or perhaps even stop the disease to some extent from progressing. It's been considered a disease-modifying therapy. All the drugs you see here are not disease-modifying therapies. They're considered symptomatic therapies, which means they can't halt the disease dead in its tracks. They can't undo damage that's already occurred, but they may be able to, at least for short periods of time, improve symptoms. And over a longer period of time, as I will show you in a moment, patients who are on these medications, or particularly on the combination of memantine and the other medicines, which are called cholinesterase inhibitors, they may function better over time than those that don't have any treatment at all. So that's the posture that I'll be taking. So here's some data, and I'm going to make this kind of relatively understandable because I've got complex slides to show you. But this is looking at the cholinesterase inhibitor rivastigmine, also known as Exelon, which is available in a patch, also available in an oral form. Oral form has serious gastrointestinal side effects, so the patch is much better tolerated. What we're looking at here, as you can see, the short study, 26 weeks. These are individuals with relatively early Alzheimer's disease, and all we're looking at here is what happens cognitively. The ADAS-Cog, the Alzheimer's disease kind of assessment scale cognitive section, is not something you and I are going to do in the office. It's a very lengthy cognitive screen, but it's the gold standard that the FDA likes to use for determining change in cognition in Alzheimer's disease. And what you see here is that particularly at the effective dose, this is the oral, which is the high dose, 6 to 12 milligrams, at the end of 26 weeks, the patients are actually a little bit above baseline cognitively versus those on placebo and lower dose, placebo being in yellow, who are starting to decline. Again, a very short study, but showing some benefits versus placebo. Here's another study, and in this one, we're looking at another cholinesterase inhibitor, donepezil, also known as Aricept. And here we're looking at a study over 48 weeks. And we're looking at patients, again, with mild to moderate Alzheimer's disease, and they're randomized at the very beginning to either being on donepezil in blue or to being on placebo in yellow. And you find that both groups decline. So we cannot say that the cholinesterase inhibitors can halt disease progression. But those on placebo have a statistically significant greater degree of decline over 1 year, 48 weeks, relative to their activities of daily living. So the ones on drug seem to maintain their ADLs a little bit better. Again, they still decline, but they're a little bit better. This is a very interesting study. This is with another cholinesterase inhibitor called galantamine, also known as Razidine. And here what we're looking at are, again, individuals with kind of early to middle Alzheimer's disease, and they're randomized to either being on galantamine 16 milligrams, galantamine 24 milligrams, or placebo in yellow. And what we're looking at is what happens to behaviors. Now, this is, again, a 5-month study, relatively short study. So in the beginning, nobody really saw any behavioral problems. But what you find is that over time, those that are on placebo begin to develop behavioral problems versus those on the cholinesterase inhibitor who tend to kind of maintain the same kind of behavioral stability that they had at the outset. Now, what about memantine? What about the other class of medication, which is considered an NMDA receptor antagonist? And here are a couple of studies with memantine, one looking at activities of daily living on the right. On the left, we're looking at a global score. This is a clinician's measure. Both of these studies are basically 28 weeks, so it's about 7 months approximately. And patients are randomized either to memantine or Namenda versus placebo in both of these studies. What we find is that over this relatively short period, individuals who are on the memantine are, again, they're declining, but they're able to maintain their activities of daily living a bit better. Same thing with the global impressions, where the clinicians don't know who's on placebo, who's on drug. At the end of 28 weeks, what they're able to determine is that those on drug seem to be better clinically on a global measure called the CIVIC, which is something that the FDA requires. I mentioned to you earlier that there's a lot of data on combination therapy. Combining a cholinesterase inhibitor, does not have to be, donepezil, it could be any of them, together with memantine or the NMDA receptor antagonist. This is a 6-month study, again, relatively short, looking at cognition, looking at the severe impairment battery, because here we're not looking at mild patients. We're looking at patients with moderate to severe Alzheimer's disease. And what do we see over 6 months? Those that are on the combination therapy still remain a little bit above baseline versus cognitively, versus those on placebo that, again, starting at 12 weeks, begin to decline and indeed continue to decline at a faster pace than those on combination therapy. What about caregiver burden? We know how difficult Alzheimer's disease is, not just for patients, but also for care partners. This particular, again, placebo-controlled trial, only 6 months, but nonetheless, looked at the impact of, in this case, donepezil, the cholinesterase inhibitor, on caregiver burden. Again, finding that those on drug versus those on placebo seem to have less caregiver burden, kind of a lightening of their caregiver burden. Now, all these studies and the data I just showed you were all part of the approval packages that the pharmaceutical companies submitted to the FDA based upon which these drugs were approved. But again, there's sometimes a little suspicion about pharmacologic studies that are sponsored by drug companies, although I'm not necessarily suspicious of it because the FDA reviews that very thoroughly. But here I want to show you a study that was basically NIH sponsored by the National Institute of Health, by a colleague of mine, Ali Atri. And it's not just a short study. I showed you, the longest study I've showed you was 48 weeks, 1 year. Most are 6 months. In fact, a good trial of these drugs is 6 to 12 months. And if after 6 to 12 months, the patient is continuing to deteriorate and there's no stabilization or any kind of improvement, I would discontinue these therapies. But here, Ali Atri looked at the long-term course and effectiveness, particularly of combination therapy, combining a cholinesterase inhibitor with the NMDA receptor antagonist. So it was called a real-world kind of clinical effectiveness study to look at the trajectory, the rate of decline, the rate of progression of no treatment, cholinesterase inhibitor alone, or the combination, memantine and the cholinesterase inhibitor. Looked at in a variety of ways. Here we're looking at cognitive performance, 4 years on these therapies. Yes, all these patients progress over time. But what you see, and this is statistically significant and maybe clinically meaningful as well, is that individuals on combination therapy in general do better than those on one or the other alone, or the cholinesterase inhibitor alone, and both groups do a little bit better than no treatment at all. What about activities of daily living, functional dependence? He found the very same, that patients receiving combination therapy may experience less dependence compared with the cholinesterase inhibitor alone, as well as with no treatment at all. Again, keep in mind this is 4-year data. What about behavioral effects of combination therapy? This is a study that looked at that. Here we're looking at, again, memantine with donepezil, one of the cholinesterase inhibitors. And what you see is that not only was there a slowing in behavioral problems occurring, but these patients, at least over 6 months, stayed above baseline. They did better behaviorally, and they did not start to develop behavioral problems, at least over a short period of time. And then here's the last study that I want to show you. Again, it's not a pharmaceutical company sponsored study, a large study looking at persistent treatment with combination therapy and what impact it may have on clinical progression of Alzheimer's disease. This was a big study, over 600 patients, some of them followed for over 20 years. And what they found was that persistent drug treatment produced not only statistically, but clinically significant impact on the progression of Alzheimer's disease in the cognitive areas, in activities of daily living, and then in global clinical measures, which is what you and I do in the office. And these positive effects were even seen in advanced Alzheimer's disease. So again, just to kind of quickly show you some of this data, additional data on behaviors. This is a 5-month study looking at galantamine. Again, patients remain stable behaviorally on drug. If we look at a variety of different behaviors, now we're looking at a cholinesterase inhibitor in moderate to severe Alzheimer's disease, you find that a lot of the behaviors improve. And then some of the behaviors don't deteriorate nearly as much on drug versus placebo. With memantine, there's been a Cochrane review, a very prestigious group of reviewers looked at all the data. And what they found was that basically in moderate to severe Alzheimer's disease, there was a beneficial effect of memantine at least at 6 months on cognition, ADLs, and behavior. There was significant improvement in clinical measures. And patients who were taking memantine appeared to be less likely to develop agitation. My European colleagues often like to keep patients on memantine long-term because of this finding that they're less likely to develop agitation later. Doesn't mean it's impossible, they can, but they're less likely versus being on placebo. And even in mild to moderate to severe throughout, as well as they found in vascular dementia, there were significant benefits of memantine treatment in a variety of areas, and it was well tolerated with minimal adverse side effects. There have been meta-analyses done of memantine on behavior. Again, there was a study looked at a study of 6 studies that was pooled together in moderate to severe Alzheimer's disease and showed that basically starting at week 12 and beyond, memantine significantly improved behavior scores versus placebo. So again, this is kind of an overview of the major studies that have been done relative to behavior with memantine. And as you could see, anything to the left of the 0 found benefit for the drug versus placebo. And again, the benefits were not just in decreasing behavioral problems, but they were also things that were able to be seen clinically by the investigator. Some of the behaviors that tend to either improve or to be less likely to evolve include agitation, aggressive behaviors, irritability, lability, as well as delusions. So again, keeping patients on these therapies, the cholinesterase inhibitors and memantine, seems to produce both statistically as well as clinically significant improvement, not in all, but in some patients with both mild to moderate as well as severe Alzheimer's disease, when we look at them relative to measures for cognition, activities of daily living, behavior, and global or clinical measures. Thank you very much.
So this is a debate, or supposed to be a debate, so it won't surprise you that I'm not going to totally agree with George. George is without doubt one of the best geropsychiatrists, maybe the best I've ever known. And before drugs came out, he cured all my patients for me. Once drugs came out, I thought his success rate went down a small percentage. He would disagree with that, and he most probably is right. So I'm going to look at the problems of using medications, but I'm predominantly going to focus on the fact that there are lots of things that you can do for people with Alzheimer's disease or dementia, and therefore you need to screen early and start doing these things early, because the outcomes are very good and at least as good as drugs, if not better. When we look at cholinesterase inhibitors, there is evidence, as George showed you, that may slightly delay the loss of brain function in persons who have mild to moderate Alzheimer's disease. The positive effects are on thinking skills and memory. The Cochrane analyses that I looked at suggested that about 14 out of 100 people respond. So the response rate is precision medicine for a small subset of people. And I have found this with my patients, that I'll put them on the cholinesterase inhibitors. And as George said, after 3 months, if it doesn't seem to be working, you can withdraw it. My favorite patient was a patient who came to me who'd seen another geriatric psychiatrist, and he was on not Tacron, but on donepezil. And I said, I don't think it's doing him any good. We can stop it. A week later, his daughter phoned me and said, you know, he's gone crazy. This is horrible. You can't use this drug. What are we going to do? I said, well, if you like, you can put him back on, but I'm not certain he's gone as crazy as you think, and I don't think it's because of stopping the drug. So he came back to see me 3 months later, which shocked me because I didn't think the daughter would bring him back, but she brings him back and said, you know, since we got him back on the drug, he is doing remarkably well. And the guy said, yes, that's because I never went back on the drug. So I think it's important that if you're going to use drugs, you look at, do they work, and try a withdrawal period after somewhere between 3 to 6 months to see if they are still working. That, I think, is an important part of this. There is some research that George showed you that patients with Alzheimer's disease cope better in everyday life. The Cochrane analysis I looked at was not as excited about that as the studies that George showed you. Most of the studies that have been done last for 6 months, so it's difficult to know what the long-term effects would be. And George showed you some of the studies. I found a 5-year Swedish study that showed that the mini mental status score was higher at the end of 5 years in the people on drug. Now, the higher point was 0.13 out of the 30-point scale. I don't consider this a positive response. Now, in some people, if you improve behaviors and stuff, it's worthwhile doing it. But this amount of mental status improvement is, in my mind, at least questionable. I'll show you why in a second. And the other thing to realize is I'm a geriatrician, so I hate drugs just because they're drugs. And they all have side effects like nausea, vomiting, loss of appetite, dizziness, or diarrhea. Depending on which medication patients take, 1 to 3 out of 10 people feel nauseous or vomiting. This does not improve your outcome. So I think it's very important not just to look at cognition with the drug, but also to see what the outcome is. So are there other things you can do that will do better? Well, the world, as we know, is full of anti-vaxxers. So with Jeff Shearer, we decided and got some funding from a charitable organization with no drug company support to look at the effect of vaccinations on dementia. And I must tell you that I was amazingly skeptical and was absolutely certain we would see nothing. So the first one we did was Zostavax, the old herpes zoster vaccination. And we looked both in a VA study and in a community study, the market scan study. And what you see here is that in both studies, there was a remarkable decrease in dementia in people who were vaccinated with the Zostavax. Nearly half of the people compared to if you didn't get vaccinated. And we did a lot of control studies to make sure this wasn't just that the people who chose to do vaccines were different. We can't totally exclude that, but it might have been. We then looked at the tetanus, diphtheria, pertussis vaccination and dementia and found exactly the same thing. We have looked at people who got both, and we show that they get an even better response. We're busy doing some animal studies at the moment, but the suggestion is that these vaccines alter the regulatory T cells, and therefore, because a lot of dementia is due to inflammation, they block the inflammation that's occurring. There's ongoing studies. I don't know that they totally convince everybody that you should have your regular vaccines when you get older, but I think having looked at this, I'm really glad I've had my vaccines. Let's put it this way. The other thing is in diabetics, we know that diabetics develop dementia much more quickly than non-diabetics, and they don't have Alzheimer's disease, although the literature is full of calling diabetics with dementia Alzheimer's. When you look at it, they are much more likely to have some form of vascular-like dementia. And we have looked at this, as have other people, in detail. And doing epidemiological studies, it is fairly clear that you again see in people getting metformin less dementia than in people who don't get the metformin. This is not related to changes in vitamin B12 that might occur in people on metformin. And it is sort of interesting. Metformin is clearly the drug of choice for type 2 diabetics for many reasons. And you should not get too carried away about every time a new drug comes out, the companies manage to sell us that the SGLT2 inhibitors are much better than anything. And then a few years down the line, we find that that's not true. So metformin, which I've been using since I started medicine nearly 50 years ago, is an excellent drug. It wasn't available when I first came to the States, and I argued all the time with my diabetes mentor that he should be using metformin. He told me I was crazy. It turned out afterwards I was most probably right. So now why else do we not rush to drugs? So the first thing is there are many reversible causes of mild cognitive impairment and dementia. These go by the dementias mnemonic, and you have to look for these carefully. Anybody who's got mild cognitive impairment or dementia should not be on an anticholinergic drug. It makes a huge difference to stop those drugs, and even if they've got early Alzheimer's, they're going to do much better if they're not on the drug. The next thing is emotional. People who are depressed often get severe, basically, dementia or cognitive dysfunction along with it. My favorite patient came to me from the Washington University program, where they told him he had severe Alzheimer's and there was nothing to do. And he kept on crying while he was with me the whole time. So I sent him to Dr. Grossberg, and I said to George, I think this guy is very depressed. He needs ECT. George gave him ECT, and about 6 months later, he was much more functional. So depression is an important cause to look for. Obviously, metabolic causes like hypothyroidism and B12 deficiency. Very important to realize if you can't hear, you can't see, you're going to have cognitive dysfunction. And checking whether people can see, getting wax out of their ears. In our nursing home a number of years ago, we had students go through the nursing home, take wax out of the people's ears, and it improved the mini mental status by 1 point, which is somewhat better than you're going to see with any cholinesterase inhibitor. Normal pressure hydrocephalus is treatable. That's the ataxia, incontinence, and dementia. Tumor and other space-occupying lesions can sometimes be treatable. Infection, the old one when I started out as an intern was syphilis all the time, but now chronic infections. And we see a lot of people in Missouri who have chronic sinusitis with infection, and you treat the infection and their memory improves. We have to remember that people with atrial fibrillation are having small strokes regularly with it. And if we don't treat it, if we don't put them on something that inhibits the formation of the clots, they will finish up with dementia. And alcoholism, hard to treat, but still okay. And then sleep apnea, major cause of mental dysfunction, cognitive dysfunction in older people. In our nursing home population, about a third tended to have sleep apnea. You've got to pick this up earlier because CPAP is not well tolerated when the dementia is fairly far advanced. What about exercise? This is a meta-analysis. You saw George's meta-analysis. This meta-analysis for exercise is showing a slightly better in favor of exercise than for the drugs that are available. And I think we have to recognize that exercise will push more oxygen to the brain. And if we do it, and we do it in groups where we socialize, we get good outcomes. The Mediterranean diet is associated with a reduced risk in Alzheimer's disease. This has now been well shown in many studies. The MIND diet, which is the American version of the vegetables and fruit, does the same sort of thing. We need to recognize the phenols in these fruits and vegetables produces a decrease in inflammation. And if we go ahead and basically use extra virgin olive oil, this study was done in Spain using a liter a week for the patients taking it. There was a further marked improvement in memory with extra virgin olive oil. Beware that if you're an American and you take extra virgin olive oil and you haven't been taking it, you're going to get severe diarrhea. My favorite patient was one who went on the extra virgin olive oil, got diarrhea. I told him to cut back. He said, no, my memory's much better. And then he came in with a broken leg because he was rushing to get to the toilet because of the diarrhea from the extra virgin olive oil. So that's the major side effect of extra virgin olive oil. And you should take as much as you can. It seems to be good for you. This here is the finger study. It was done in Finland, obviously, a 2-year multi-domain intervention of diet, exercise, cognitive training, and vascular risk monitoring versus control to prevent cognitive decline at people early in their aging process who were at risk for poor outcomes. And you can see here that, in fact, you did improve executive function and processing speed, but not necessarily memory. So if we look at it, a fruit and vegetable diet with the addition of fruit, exercise, and some brain exercise appears to work very well. This will improve your cognition. You heard Max Zubatsky talk just before this about cognitive stimulation therapy. I brought Martin Orrell out to the United States many years ago. He was a psychiatrist who started doing this in London. And we need to point out that basically in the United Kingdom, the NICE people now recommend this as much as they recommend drugs. They say that it works well. And the NICE people, their equivalent of our FDA, are not nice at all because they look at costs, they look at other outcomes. When we first started this at our NHC nursing home in Maryland Heights, we showed that in nursing home residents, we could markedly improve the SLUM score and the BIM score when we put them into a cognitive stimulation therapy program. I'm showing you here the data from Perry County. Max showed you some of this data as well. Not only do you improve the SLUM score, but as importantly, you decrease depression and you improve quality of life. The experience we've had with cognitive stimulation therapy suggests that it has virtually no side effects and works at least as well, if not better, than drugs. This is a Cochrane database from Bob Woods and the other people who did the original data studies with this. And again, you will see here that they're getting a very good outcome with the ADS-COG. Reminiscence therapy works. It does not work as well as cognitive stimulation therapy, at least according to the Cochrane meta-analysis. We developed at the VA here, the Cardinals Reminiscence League, and our local Alzheimer's disease has been offering this for a number of years during the baseball season. I'm not certain whether they've got back to doing it this season, but the way the Cardinals are playing at the moment, despite having won the last two games, it might not work nearly as well. So what I've tried to tell you, I think, is that you need to screen rapidly in physician offices. Primary care practice needs to screen at least once a year, ideally doing the annual wellness visit, medical visit. You get well paid for it, you screen. And if people have mild cognitive impairment, if they basically have dementia, you should use what we've now developed, a computer-assisted management algorithm to help health professionals recognize the treatable causes. Really important to look for treatable causes because those are curable. And then if you can't find any, I believe you should provide a lifestyle modification of exercise and a Mediterranean diet to patients and families. I would ask my patients if, in addition to this, they would like to go on a cholinesterase inhibitor and or memantine. And if they did, after 3 months, I would basically check whether they had improved their cognitive function. If they hadn't, I tended to take them off the drug. And then you have to always check for caregiver stress in the primary caregiver. Very poor outcomes occur in people with Alzheimer's disease as the caregiver becomes stressed. And providing programs to alleviate stress for the primary caregiver is absolutely key. I would prefer to see the money that we spend at the moment on basically drugs for Alzheimer's disease to be spent on caregiving to improve outcomes. I think the CST programs also should be there for everybody. And obviously, that's a very small number of people at the moment. I think they're excellent. I haven't mentioned two other foodstuffs. Curcumin, there is one study out of UCLA suggesting that curry is most probably good for you with dementia. And the other study is giving yogurt. And George didn't mention it, but he often does in his lectures. There's a Chinese study that showed that oligomanate, which works like yogurt, actually improves memory to some extent. What these do are work on the microbiome, and they decrease inflammatory disease in the person. Data is not good enough at the moment to suggest the oligomanate. George, I think, is going to be involved in one of the studies in the United States, and we can hope that these will be better. George mentioned adenosine, which I'm not going to learn how to pronounce properly because all 10 of the FDA primary reviewers said it should not get on the market. 3 have now resigned from the FDA because of them putting it on the market. It's a questionable drug at the very best. It leaves you with a swollen brain, and I'm not certain that swollen brains are good for people. I'm also uncertain that getting rid of amyloid plaque is good for people. This is based on our belief from our animal studies that beta amyloid actually improves memory at low doses. As you increase the dose, it makes the memory worse. And we believe from our animal studies that the plaque actually is protective by taking away beta amyloid. And it's only when you get large excesses you run into trouble. This is most probably wrong. I'm not going to disagree when George tells me it's wrong. But what I will tell you is I'm not very enthused about the new drug.